Mr. Chairman, ladies and gentlemen, it's a pleasure to share with you some ideas and some topics we have developed in Paris and this work in very close proximity to obstetricians and sonographers date back to a long time now. And we began to work very closely with obstetricians and sonographers, and that's what I try to show you in this view. The heart, it's very simple to organize a detection in a large population, in large scale in population. You have now in France from 2005 an obligation, and it's a legal regulation that every woman examined must have in the records, must have the four-chamber view, and the four-chamber view is able to detect complex anomalies and asymmetry, right-left anomalies. And as we see here, this view in the right ventricular pulmonary view of profile. And every woman must have these two views in the determinations. And it's very simple now to be legal expert in case of misdiagnosed or absent diagnosed or false negative. The first thing, where is the chamber view? Where is the arterial view? It's a regulation for every sonographer in France to have these views in the file. Historical fetal heart examination. We were very lucky in France as pediatric cardiologists. I'm not obstetrician, I'm not sonographer, I'm a pediatric cardiologist. And we were very happy to work with a counterpart, with colleagues in obstetrics, very involved in the fetal heart examinations, very interested by cardiovascular disease. And we began to very early the fetal detection and to demonstrate for pediatric cardiologists. It was not to demonstrate in obstetrics, but to demonstrate to pediatric cardiology the real usefulness of those fetal detection of congenital heart disease. And we start with other pediatric cardiologists and obstetricians. We had not meeting, but it was to work very closely with the teams in Antoine Becler, in Port-Royal, in every center, and in those. We start with ideas, some ideas, very simple ideas. The first idea was we start from fetal echocardiography, but we have not to do a technique. Fetal echocardiography is a technique. We have to do an extension of a specialization in obstetrics and pediatric cardiology. And this specialization is not fetal echocardiography, but it's fetal cardiology. And that became fetal cardiology or prenatal cardiology. It's not a technique, it's medicine. Two separate words in the 30 years ago. Two separate words. The pediatric cardiology have the knowledge and expertise in congenital heart disease without access to the patient. And the obstetricians have the access to the patient, but doesn't know and know the expertise in pediatric cardiology and congenital heart disease. So we have to organize bridges between the two levels of profession, the two professions, to organize this kind of organization. This extensive collaboration dates back as early as 1985, and we began from this date, and it's always my director, Professor Jean Cachaner, wrote papers at this time. It's always true. It's always with papers wrote with Dr. Anderson and all his colleagues and friends from this time to define the objectives, to reassure the parents in case of antecedents, to detect complex disease, to detect life-threatening postnatal congenital and avoiding losing time, and to detect from the heart associated anomalies. It was not to say the heart will be normal or not, but the objectives were real medical objectives. To organize everywhere a methodological training of sonographers, and that has been stated by other colleagues here. And every profession has to do his job. The first state is a state of detection in the general population, in a low-risk population, and the second stage is the confirmation and establishing the prognosis of the disease. And we were very methodological, and we all lived, Dario and others, and Rabi, this very organization of the work. In the 80s, it was to extend the four-chamber view. In the 90s, it was to extend the arterial view. Four-chamber view, complex disease, arterial view, emergency, and life-threatening congenital heart disease. And now it's more sophisticated. And in 85, I remember a meeting with Professor Planchet of Maryland Long, with Professor Papiernik and Friedman, Professor Henrion, chiefs, directors in obstetrics, and we made a striking separation. What we are able to do postnatally and what we are not able to do. And we separate univentricular repair in congenital heart disease and biventricular repair in congenital heart disease. And contrary of many, many countries, it was not the option of the parents. When we are able to repair a congenital heart disease, the termination of pregnancy was not on the scope of the patient, of the surgeon. It was not really the option of the parents. It was very discussed. You can imagine the discussion in this field. And all was to obtain an extensive detection of congenital heart disease and avoid inappropriate termination of pregnancies and maximize the chance of appropriate management. And we published in this field something remaining in the field of pediatric cardiologist meetings, that it was a simple idea. A close collaboration between obstetricians and pediatric cardiologists leads to a prenatal detection of congenital heart disease. It was simple, it was like that, and it was applying in every country. And to show you the results of this policy of examination in a large-scale population, Île-de-France, Paris and Île-de-France, is around 15 million of inhabitants, and we organize this system in every city of France with pediatric cardiologists working in every city of France in this field. And to show you the results, we don't speak as pediatric cardiology. It's only observations from epidemiologists and regulations authorities in France, in INSERM, Institut National de la Recherche Scientifique. There is a paper from Eurocat observation, prenatal diagnosis of 6 major malformations in Europe, a population-based study published under the authority of Dr. Garen from Denmark. You see the study period, it's 90 to 94, and the Eurocat group has written, there are major regional differences in the prenatal detection rate of cardiac malformations, with the highest detection rate in France. It was 15 years after we began this. And for example, in 20 years ago, it has been quoted that stated that single ventricle was detected in more than 90% of cases. And she writes, we think that the difference is explained by a more specialized level of ultrasound investigations in France. And she continues, the difference between France and the other European countries concerning prenatal diagnosis and terminations of pregnancy has been known in the Eurocat network for many years and is documented for other groups and malformations in several publications. It's not from French, it's not from our groups, it's written from Eurocat group. And the third idea was that the behavior in prenatal must follow the postnatal results. And that's the collaboration between obstetricians and pediatric cardiologists. If you want to say that an ventricular heart is indication to terminate a pregnancy, you need not pediatric cardiology. Fetal cardiology is in the hands of obstetricians. But to work really, we, as obstetricians, sonographers, pediatric cardiology, have to learn to make the difference in complex disease, for example, between the complex disease appropriate to palliative surgery, as Fontane's circulation, or complex disease inappropriate to have those 20, 40, 30, 40 years, even 40 years. And you have to remind of the fact that a baby born with an univentricular heart in this year have a life expectancy of more than 30 years of life in appropriate congenital heart disease. This concept was very controversial. And I show you only two references of very estimated colleagues in obstetrics. Vladimirov, in not so long time ago, who written in American Journal of Public Health, fetal echocardiography is difficult, time-consuming technique. The impact of routine screening for congenital heart disease appeared relatively small. And Josh Koppel, had written that there is no difference in median length of hospitalization, survival, and median cost. And this is the quality of our profession. They stated that their statements have to be proved if it's true or not. And we have to work to prove that it's not true, and there will be interest for the patients to detect congenital heart disease. And we worked in a focus of transposition of great arteries, and Bonnet, a colleague in Hôpital Necker, had written, and we had the work published in Circulation at this time, that prenatal diagnosis of TGA reduces mortality and morbidity after congenital heart disease. That's a paper very frequently quoted in prenatal literature, because it's more than 300 times in literature of level 1, and it's a proof of validity and efficiency of training and extension of training of sonographers and extension on fetal cardiology in the general population, low-risk general population. We have learned a lot of things. I put this slide after the communication of Rabbi shows that we are very concerned by inappropriate terminations of pregnancies. And inappropriate terminations of pregnancy, not because the imaging is not good, but because we were not and we are not sufficiently efficient in the natural history of congenital heart disease. Rabbi showed you the difference between small ventricle, left ventricle, hypoplastic. Okay, it's a very severe congenital heart disease, hyperplastic left heart syndrome. It's possible to live, but it's surgery very complicated, and the results are not so good 15 or 20 years after the Norwood procedure. It's not so, the battle is not over. But you have to make the difference between in small ventricles hyperplastic and small ventricles not filled because problem of admission in this left ventricle. Rabbi showed coarctation of the aorta. It's not so simple, because coarctation of the aorta is a spectrum of disease of very, very severe malformations. And you have what we called in pediatric cardiology rehabilitations of arteries or ventricles. rehabilitation of a left ventricle, rehabilitation of a right ventricle, and those natural history is mandatory. It's not only imaging, it's mandatory because to know this, because it's a way to make the part between the appropriate cases to envision fetal cardiac surgery or the good case and the inappropriate cases for fetal surgery, for fetal dilatation of aortic valve or pulmonary valve. And I show this, it's not born in 2000, it's born in 20 years ago, in 1990. And you had this imaging 20 years ago in a very small left ventricle with very severe disease, and it was called hypoplastic left heart for sure, with a very small ventricle and here a very small subaortic pathway. And this is a spectrum of those diseases. So, coarctation, aortic valve, subaortic, mitral valve, supravalvular annulus mitral valve. Every part of left outflow tract for left ventricle and outflow tract must be checked. And this baby in 1990 was, I said it's probably not hypoplastic, what chance, it's a very severe disease, but it's possible to envision, to have the perspective of surgery efficient. And this baby was, the parents chose to continue the pregnancy, and surely it was a very, very severe malformations of the left ventricle. You can see the history. At birth, it was called hypoplastic. And I phoned to the surgeon, Professor Pascal Vouet, to have him to repair the coarctation of the aorta. And it was called hypoplastic. It was not. There was repair of a coarctation at day 5, resection of a subaortic stenosis at month 18, intervention procedure and operation, intervention of Ross procedure at 4 years, Osler at 16 years. You can see the story of this child. But you can see that at the end of this course, surely it was not a hypoplastic left heart. Should this baby have been terminated? Okay, we see a small ventricle on fetopath examination, fetopathologic autopsy, small ventricle, small aorta, small subaortic. Okay, we say this baby has been terminated. But giving the chance to have the recovery of the ventricle, now you can see a normal left ventricle after a very, very severe way. And Thomas is born in 1990. He has something like a Shawn malformation. He was escaped from a termination of pregnancy. He is living with a Ross procedure. And you can see that we are very friends. And we are very friends because this baby was a medical doctor, medical student now, and he want to be cardiologist, and is very, very brilliant, very smart young. So you have to remind this fact. It's not one case. Now, the difference between sonographers and obstetricians and us in pediatric cardiology, that we follow the patients until now their adulthood. And we have all these lives elapsing before us. And it's very, emotionally, it's very, very complicated sometimes. And another, we are not speaking about by ourselves. It's INSERM, in the Paris Registry of Congenital Malformations, and the French Authority of Regulations, Institut de la Recherche Scientifique, and they made an audit of detection of congenital heart disease in Paris and Île-de-France, under the auspice of Baba Kosoud and François Goffinet and others. And they made this audit to have the trend and the history of fetal detection of congenital heart disease. It's really an audit. And briefly to show some data, that INSERM, c'est l'Institut national de la recherche scientifique et médicale, de la recherche médicale et le registre de Paris. You see that in the early 80s we began with very few congenital heart disease detected prenatally, and in 2000 it was 60% of cases. And when we focus to 4 congenital heart disease, this paper has been published in Pediatrics in 2005. And when you focus on 4 congenital heart disease, you can see that between at the end of the century, we had in Paris more than 70% of TGA detected, 70% of fallow or conotroncal malformations detected, 90% of hypoplastic left heart syndrome, and 42% of coarctation of the aorta. And this is not from the pediatric cardiology, it's from the epidemiologist authorities. I'm neutral in this. And when you see the results for termination of pregnancy, you can see that for sure we have a lot of termination of pregnancy in hypoplastic left heart, but it's not 100% or 99% of termination of pregnancy. You can see that it's 65% to terminate the pregnancy in hypoplastic left heart. And you can see that in transposition of great arteries, 0% in Paris in those days has been terminated, 0% in transposition of great arteries. And I don't say, as pediatric cardiology, is from the registre de l'INSERM et le registre d'épidémiologie de la région parisienne. And you can see, this is to answer the publication from Vladimirov and Koppel and others. So it's a discussion, it's a very close discussion, acute discussions. And to show, as pediatric cardiology, I'm always in distress when we don't speak about transposition of great arteries, so I put forward a few words about transposition of great arteries. Simple TGA is isolated without associated malformation, without chromosomal anomalies. It's an emergency that modifies the neonatal management when you detect prenatally. And that it is proved now that it's useful to detect by several publications in level 1. And I put publication of Necker. And you can see the history of this detection of transposition of great arteries. And this is a good evaluation of what happened in 30 years in our regions. You can see that in 84 we had only 2 detection of transposition of great arteries. And you can see the evolution throughout the years. And the 10 past year, you can see that in around 300 patients with simple TGA or small VSD TGA has been detected in Paris. 85-90% are inborn in Necker and operated in Hôpital Necker in Paris. And you can see the evolution of the percentage of survival, that we have the feeling that the game for TGA is over. There is a prenatal detection on a large scale of population of TGAs. TGAs are managed appropriately with deliveries in structures where there is prenatal, obstetrics, neonatology, pediatric cardiology, and surgery. It's very important. There is pediatric cardiologist in the delivery room in case of emergency in the delivery room within the first minutes of life. I remind you that a transposition of great arteries is in 4% of cases in imbalance in hemodynamical threat in 4%, 3 to 4% of cases. So pediatric cardiology is here. Now it's possible to detect in the first trimester. And I show to finish only the results in transposition of great arteries. And you can see that the rate of terminations is 0. And you can see that the rate, and this is not from pediatric data, it's once again from the INSERM, it's the study, EPICARD study, with percent of prenatal diagnosis of around 90% in TGA, with a very small amount of interruption of great arteries. This amount is because of associated malformations or dysfunction of a left ventricle. It's very important. And to finish, I show you the first case of fetal detection in France for TGA. You can see the switch has been done. The switch operation has been done in Hôpital Maryland Long in 1985. Young now is around 27 years of age, with normal four-chamber view, with a normal function of the ventricles, and you can see the normal aorta dilated because it was the technique, and you can see that this guy is doing very well. He's without problem in his life. He's a manager and he's sport. He makes sports and another case of young with transposition of great arteries. You can see that prenatal diagnosis, acute acidosis at 3 minutes of life. It was terrible. He had a Rushkin procedure in the delivery room. It was done by, I think it was still Philippe Bonhoeffer who have done this. And the switch at 3 days of life, you can see the prenatal diagnosis. It's of this baby, of this condition, with the parallel aspect of the two vessels, and the aorta anteriorly arising from the right ventricle. You can see here. And this guy is very happy to have a prenatal diagnosis and the management. Thank you for attention.